viral infections of oral cavity. So there are a lot of viruses which cause acute infectious diseases. We are specifically dealing with viral infections of oral cavity. So what is a virus actually? Virus, it's basically a submicroscopic entity which has the capability of reproducing in humans especially. So the structure of virus, if we see, it is made of either a RNA genome or a DNA genome. So depending on the presence of the genome, viruses are of two types: the DNA viruses and the RNA viruses. This central genome, either the DNA or RNA, they are just enveloped by a nucleocapsid protein. Okay, and this nucleocapsid is then enveloped by a outer envelope which is nothing but made of protein, and a variety of extracellular receptors are present on this structure. So this is the basic structure of virus. Actually, the term virus was derived from Latin word that is mean nothing but venom or poison. So it has been reported that there are like lot of viruses: RNA viruses, DNA viruses, influenza virus, polio virus, Coxsackie virus, herpes virus. So all these viruses, majority of the viruses, once they cause an infection in humans, they tend to provide immunity to the individual, so that reinfection does not occur. So that is the characteristic of virus. So today in our class of viral infections, we'll be studying about the commonest viral infections which we see majorly affecting the oral cavity: herpes simplex virus, varicella zoster virus, there is the Epstein-Barr virus, then the enterovirus, that is the rubeola, paramyxovirus. Then the commonest and the most majorly concerned is the human immunodeficiency virus. So we'll be studying each of them one by one. First, we'll be studying the herpes simplex virus. Herpes simplex virus, it causes herpes simplex group of conditions. Okay, it can cause herpetic stomatitis, herpes labialis, herpetic gingival. So what happens? What is the basic mechanism? How the herpes simplex virus enters the body? So either through a cut or abrading of the mucosal surface, the herpes simplex virus, it enters the human body and it just starts replicating there. So the herpes simplex virus, it causes an acute infectious disease of oral cavity. Specifically here we are studying the herpetic stomatitis. So the incubation period from the time the individual is affected by the disease and the time he develops the symptoms, that is nothing but the incubation period. It is about 1 to 26 days for the herpes simplex virus. And transmission of the virus from one individual to another individual, it occurs either through close contact, kissing, or sharing of the cutlery, glasses, or whatever, wherever there is transmission of saliva. In that cases, more of transmission of herpes simplex occurs. So there are two kinds of infections. So when the individual is suffers initial attack by the virus, there is nothing but the primary infection by the herpes simplex virus. And the primary infection in almost all individuals, it's asymptomatic infection, that is the individual doesn't know that he is infected by the virus. So the person has come in contact with the affected individual, and by either any means of transmission, a droplet or saliva transmission, he has got the virus, but the infection is like subclinical one, non-symptomatic. That this primary infection is mostly seen in cases of children or younger individuals. Then once the virus enters into the body, it remains latent, and later on when it gets reactivated, then at that time you can see the recurrent infection in the body. That is nothing but the secondary infection. So this reactivation of the virus, it occurs because of either of the trauma or other triggering factors like anxiety or variety of other symptoms. So the initial infection or the primary infection, that is causing this herpetic stomatitis. So once the virus enters either through mucosal cut or upbraiding, it remains latent or it enters into the sensory or autonomic nerve endings. These virus remains dormant or latent in the ganglia. So once the virus replication occurs, then you can see the symptoms in the oral cavity. There are two types of herpes simplex virus, that is the herpes simplex virus 1 and the herpes simplex virus 2. Herpes simplex virus 1, it typically affects the individual upper half of the body, that is specifically the face, lips, oral cavity, the tongue, gingiva, palate, buccal mucosa, all are affected. Specifically the upper half of the body is affected. Whereas the herpes simplex virus 2, it affects the parts on the lower half of the body, that is the genitals specifically. So what is the difference between the primary infection and the recurrent infection? For the primary infection, it is the initial infection, right? So no antibodies are detected in the individual. Recurrent infection, it's like the primary infection has occurred years back, the virus was dormant and then it was reactivated. So sufficient time is there for the antibodies to develop. So antibodies are detectable in cases of recurrent infections. So the primary herpetic stomatitis, as we have seen, it is the initial attack of the children. So it is seen in cases of children and younger adults. So the transmission is same, either droplet spread, saliva transmission basically. So the affected individual, he is a source of potential infection for other unaffected individuals. So initially what happens is, you will see systemic or generalized manifestations, that is the development of fever, irritability, headache, pain on swallowing, on lymphadenopathy. Yeah, lymph nodes, lymph glands will show swelling, any lymph node like the axial or the cervical. And the mouth will be painful because the gingiva is like erythematous, inflamed and edematous. So patient will have difficulty in swallowing food. So that counts for the painful gingiva. And as time progresses, small yellowish fluid filled vesicles will develop in the oral cavity on the side. Most commonly affected are the lips or the buccal mucosa, the tongue also. So the yellowish fluid filled vesicles will be developed. As time progresses, these fluid filled vesicles rupture. They rupture and they release the contents, and they form into ulcer. There is a shallow shaped ulcer with which is covered by a yellow membrane and surrounded by a erythematous halo. So the vesicles rupture into ulcers which are surrounded by a erythematous halo. So these ulcers, gradually they heal by themselves within 7 to 14 days. This healing does not leave any scar. So the herpes simplex infection of the gingiva, it manifests as vesicles which rupture on their own and leave no scar, and healing occurs itself. So the treatment for this herpes stomatitis is symptomatic treatment, or symptomatic relief may be given, and antiviral drugs they help to significantly control the spread of the virus. Then herpes labialis. Herpes labialis, actually it is a recurrent form of herpes simplex infection. So it is since it is a recurrent form, it is mostly seen in cases of adults. Only the primary infections are seen in children. The recurrent infections are seen in adults only, and it affects all of the oral cavity, the lips, tongue, buccal mucosa, gingiva or palate. All of them show this recurrent herpes infection. And once what happens is, when the primary infection occurs, the virus will remain latent in the sensory nerve endings. So on activation, on stimulation or reactivation, this reactivation may occurs by many triggering factors like trauma to the area, or in cases of anxiety, or in periods of menstruation, or a variety of other triggering factors are present. All these triggering factors lead to reactivation of the virus. So the virus is reactivated and it spreads along the distribution of the sensory or autonomic nerve endings. So there is more widespread widespread area of the disease. So all along the course of sensory nerve endings, you get to see the disease. So here in cases of herpetic labialis specifically, the herpetic vesicle is seen on the site of inoculation, that may be the lip, or along the site of the dermatome affected, that is along the site of the sensory nerve ending. On that particular area only you can see the vesicles, yellowish fluid filled vesicles. These vesicles may be just about 1 mm in diameter, very small. These vesicles eventually they rupture, they lead to formation of ulcers which are covered by erythematous halo, and specifically in case of herpetic labialis, the brownish crusting of the lip is seen. What happens is the ulcer heals by desquamation and eventually they form a brownish crust on the lower or upper lip wherever the site of inoculation is there. So healing is self-healing, that is once the vesicles rupture, ulcer forms, it automatically it has to heal by desquamation, and there is no tendency for recurrence in cases of herpetic labialis. So before the vesicles develop, initially you can feel little bit feeling of tautness or redness or tightening of the skin or pain in that area, or pinkish color inflamed area may be seen preceding the formation of the vesicles. So diagnosis of herpes is done by isolation of herpes simplex virus and characteristic histologic picture. So we'll be studying histologic picture now. So herpetic whitlow is specifically seen in the medical or dental personnel because of auto inoculation. When the dentist hand or the medical professional doctor's hand, it comes in contact with the herpetic vesicle or the fluid rupture of vesicle occurs, the viral infection automatically occurs on the fingers. So that's nothing but the herpetic whitlow. So the inoculation of virus occurs on the fingers and it leads to ulcer formation and permanent scarring occurs in that area. So these are the clinical presentations of the herpes simplex virus. So when you see when you are about to diagnose the lesion, the microscopic picture gives a correct diagnosis of which lesion it is. So clinical pictures are almost always diagnostic, but you want to know what exactly it is. So herpetic isolation of herpes simplex virus may be done from the base of the vesicles. When you rupture the vesicles, then you get to isolate the virus. So the picture of vesicle, actually the vesicle whatever is we are seeing in the herpes simplex infection cases, all are intraepithelial blisters. That is just beneath the epithelium you get to see a fluid filled blister. You have to differentiate these intraepithelial blisters from other diseases or other skin diseases like the erythema multiforme or pemphigus, because those are also like intraepithelial blisters only. So differential diagnosis has to be carried out, and that can be done correctly by microscopic diagnosis only. So the infected cells, water cells are infected by the herpes simplex virus. They show swelling of the cells with pale eosinophilic cytoplasm. That is the characteristic presence called as the ballooning degeneration of cells. Because the most of the cytoplasm will be empty and the nuclei, it will be just large and shifted to one place. So that is an appearance of ballooning degeneration. And the presence of Leibstedt's body or intranuclear inclusions is also characteristic of herpes virus. Here what happens is Leibstedt's bodies are nothing but ovoid homogeneous structures seen. The cells are staying eosinophilic, they are ovoid and they appear within the nucleus and they displace the nucleolus to one side. And other characteristic feature of microscopic picture is the presence of multinucleated gain cells. The clumping of cells occurs, so they become multinucleated, and these multinucleated gain cells are also known as Zank cells. So microscopic picture of herpes simplex has three characteristic features. One is the ballooning degeneration of cells, other is the Leibstedt's bodies, and other is the Zank cell. So this histologic picture, you can see towards the right side that there is clumping of cells, that is the multinucleated gain cells, only that can be seen clearly here. So diagnosis is by clinical presentations and virus isolation, immunofluorescence staining, and serological assay also. Because the fluid or the blister is intraepithelial, you have to differentiate it from other infections, other viral infections or bacterial or skin diseases like the herpes zoster, impetigo, pemphigus, and epidermolysis bullosa. Though epidermolysis bullosa and all are relatively very severe forms of the disease, and herpes simplex, mostly it is like on the area of distribution of the sensory nerve, so it has a very typical clinical presentation. So now this is about the herpes simplex virus. So you should not confuse Herpangina with the herpes simplex virus because of the name. Actually, Herpangina, it is caused by Coxsackie virus and not herpes simplex virus. So we'll go with the other commonest viral infection caused by varicella virus. So varicella virus, actually it's also known as human herpes virus 3 type. So it is basically a DNA virus. There is the central part, whatever is there, the genome is the DNA. Varicella virus, infection by varicella virus presents two presentations. That is, one is the chicken pox or the variola, and the other is the herpes zoster or the shingles form. When the individual affects the first attack or the initial attack, that gives the appearance of chicken pox, and shingles is a recurrent infection by the varicella virus. So we'll study both of them in detail. So transmission or transmission from individual to individual occurs either through inhalation of droplets or through direct contact or through primary infection of conjunctiva or upper respiratory tract infection, mainly through droplet spread or sharing of saliva, spreading of saliva, contamination by saliva. So that is the mode of transmission of varicella zoster virus. Incubation period from the time the individual comes in contact with the virus and the time the disease develops, it's about 2 weeks. Transmission through airborne droplets and saliva contamination. So primary infection by the varicella zoster virus gives the presentation of chicken pox, that is the primary varicella. So since it's a primary infection, initial attack occurs in cases of children or young adults. So the clinical presentation, it includes a variety of prodromal symptoms. Before even the visible rashes develop, you can see a variety of prodromal symptoms like the generalized manifestations of headache, anorexia, weakness, malaise, all may be seen. So once the prodromal symptoms start, next the rashes begin to develop. These are nothing but the maculopapular or vesicular eruptions on the skin surfaces. So these eruptions, they typically begin on the trunk first and then they spread to the other areas like the face, hands, legs. Almost all of the body is affected by this virus. So the lesions of skin, they rupture, they form crusting, that is they heal by crusting of the skin because of desquamation. These are also, the presentation of these may be like similar to the herpes simplex. Initially vesicles are edematous in origin, then they heal themselves by desquamation. So whatever be the cause, once the disease has started, once the infection has started, it takes about 10 days to resolve. So here you can see the clinical picture of this varicella infection, that is the chickenpox infection. The vesicles are fluid filled and erythematous and edematous. They just located on the surface. They are also like intraepithelial blisters only. So these blister-like lesions, when coming to oral cavity, you can see varicella virus infections on the blister development on the buccal mucosa, tongue, gingiva, and palate. These vesicles, same like the herpes simplex vesicles, they rupture, they form the fluid, they liberate the fluid, and then they form the ulcers. These ulcers heal by themselves by desquamation or by crusting of the surface layer of skin. So the scaling of the lesion occurs. So characteristic microscopic picture of varicella virus infection is nothing but so intraepithelial vesicle formation and nuclear ballooning degeneration is there, and it is erythematous in nature. So inflammatory cell infiltration is also more common here. So the varicella or the chickenpox virus, it's seen in the children. Primary infection. Then now we are going to see the herpes zoster virus. It is also caused by varicella virus. It's a secondary infection. It's a reactivated one, reactivation of the varicella zoster virus. So here what happens is, once the virus gains entry into the body of the individual, it may remain latent in the ganglia, dorsal root ganglia especially. So as it may remain dormant for a longer period of time. Once the reactivation occurs because of triggering factors of trauma or anxiety or any other form of infections, so these dorsal root ganglia are activated and they show the presence, they show the appearance of the infection, clinical infection. So herpes zoster infection is also known by other names like shingles or zona. Since it is a reactivated lesion or a secondary infection, it's seen in cases of adults. So, and it has a slight male predilection. Because of the reactivation of the infection, all of the dorsal root ganglia shows replication of the virus, and there is greater and wider spread of the infectious process when compared to the primary varicella, that is the chickenpox. So this viral infection, it occurs in 3 phases. There is the prodromal symptoms are nothing but the appearance of generalized body manifestations of fever, malaise, headache. Even before the rashes develop, the individual suffers from these prodromal symptoms. So these prodromal symptoms, they develop 3 to 4 days before the cutaneous or the mucosal lesions develop. So basically the dermatome which is affected by that dorsal root ganglia, the dorsal root ganglia is reactivated. So the dermatome which is supplied by that dorsal root ganglia shows the presentation of the rashes or the clinical symptoms. So then after the prodromal symptoms, once the vesicles develop, these vesicles are characteristic in that they are unilateral in origin. So because the symptoms are presented only in the region where the dorsal root ganglia are shows division of nerves. So these are, the presentation is nothing but the appearance of vesicles, same as that seen in herpes virus, and these vesicles are also intraepithelial and they show erythematous base. The only characteristic feature is the unilaterality of the lesions. So within 3 to 4 days the vesicles, they rupture and they liberate the fluid, they ulcerate, and crusting of the epithelium occurs. So resolution or healing occurs by on its own within 2 to 3 weeks. And herpes zoster, if suppose it is involved the trigeminal root ganglion, then the characteristic appearance of vesicles on the, so the trigeminal root ganglion, if it is affected, so you can see the vesicles vesicles in the region of the area of distribution of the trigeminal nerve, that is in the area of distribution of the ophthalmic, maxillary and the mandibular nerve. So here in the clinical picture also you can see the vesicles are fluid filled or reddish in nature, you can see, and they are unilateral, that is affecting only one side of the face. Yeah, it is affects the trigeminal root ganglion. Here the infection is seen is of trigeminal root ganglion. That is the herpes zoster infection of the trigeminal ganglia. So whatever be the vesicles, they ultimately rupture to form ulcers and heal. So when you see the oral cavity, the vesicles they may occur on any site like the tongue, buccal mucosa, uvula and pharynx. These rupture to leave areas of erosion or crusting on the buccal mucosa or tongue. So, and there is characteristic association of this zoster infection of the geniculate ganglion, that along with the presentation of vesicles, you can see characteristic pain in the ear and facial paralysis in the individual infected by the herpes zoster infection. That is nothing but the James Ramsay Hunt syndrome or the James Hunt syndrome. Here, along with the zoster infection of the geniculate ganglion, you can see facial paralysis and pain in the external auditory meatus along with the vesicular eruptions. The combination of these three features is nothing but the James Ramsay Hunt syndrome, and because it affects the ear ossicles or the auditory ossicles, hearing deficit is present along with tinnitus or vertigo. So diagnosis of this infection or the diagnosis of this varicella infection, it's just based on clinical presentations and viral culture or the cytosmear taken to demonstrate the characteristic nuclear cells, and Zhang's test demonstrates the presence of multinucleated gain cells. Cytosmear and viral isolation has to be carried out. Again, the histologic presentation is nothing but same as that of herpes simplex virus, that is the intraepithelial blister formation which ultimately lead to ulcer. Ulcer shows the break in continuity of the epithelium and it's covered by fibrinous exudate. The exudate shows deposition of fibrin, polymorphonuclear leukocytes and other inflammatory cells. So now we'll see the other infectious disease, other viral infectious disease which is affecting the oral cavity. That is the infectious mononucleosis. Infectious mononucleosis, it's also known by other names like glandular fever or Kissing's disease, because it is the mode of transmission is through salivary spread or the droplet spread or through kissing or contaminated salivary transmission. So that's why it's also known as a kissing disease. Infectious mononucleosis, it's caused by Epstein-Barr virus. Actually, Epstein-Barr virus, it's also a form of herpes virus only. Okay, the incubation period for infectious mononucleosis is 7 to 10 days. So the characteristic presentation of infectious mononucleosis, clinical presentation, it includes the association of pharyngitis along with the lymphadenopathy and the oral manifestations. So here in the picture you can see the pharyngitis. The association of pharyngitis and lymphadenopathy is very important for the diagnosis of infectious mononucleosis. So this infectious mononucleosis, the clinical presentation is seen in younger age individuals or children, and there are no sex predilection. So the lymphadenopathy or the enlargement of lymph nodes or glands may be seen either in the axilla region, cervical region or the inguinal region. But lymphadenopathy has to be present. Along with that, orally you can see the pharyngitis may be present and tonsillitis may or may not be present. If it is present, it has to be exudative. It exudes yellowish like fluid on the surface, tonsils. So based on the presenting symptom of tonsillitis, the child complains of inability to eat, sore throat, pain, and systemic manifestations like fever, malaise, headache may be present along with that. And characteristic, even before these lymphadenopathy or other pharyngitis is noticed, the individual shows generalized weakness of the body. He becomes extremely tired in nature, difficult to concentrate, lethargy may be present. And when coming to oral cavity, specifically you can see the occurrence of necrotizing ulcerative gingivitis confined to the marginal gingiva. There is destruction of interdental papilla occurs, and petechia occurs on the hard palate. And infectious mononucleosis clinical presentation is the association of lymphadenopathy, pharyngitis specifically. But histologically, when you see the infectious mononucleosis, the case of infectious mononucleosis histologically, it has to be differentiated from other infectious disease, that is the mononucleosis. Here in infectious mononucleosis, WBC characteristically, if 50% lymphocytes are present, 10% of the lymphocytes will be atypical in nature. That is, they won't have the characteristics of the usual lymphocytes seen. These atypical lymphocytes are reactive in nature. They are also known as downy cells. So that is the diagnostic feature of the infectious mononucleosis. Treatment for infectious mononucleosis includes symptomatic treatment. Along with symptomatic treatment, antibiotic treatment is suggested, because here infectious mononucleosis affects the pharyngitis, pharynx or the tonsils, right? So streptococcal infection is evident. So antiviral drugs may not act on the streptococcal infection, right? So antibiotics along with the antiviral drugs have been suggested. Rest has to be given because the patient is extremely tired. Oral symptoms resolve within few weeks as the disease resolves on its own. It is a self-limiting disease. The next common viral infection is because of the cytomegalovirus. The cytomegalovirus, it's also known as human herpes virus type 5, and transmission of cytomegalovirus, it occurs from person to person either through sexual contact or during breastfeeding or transplacental during delivery or during organ transplantation or blood transfusion. So cytomegalic inclusion disease or cytomegalic inclusion disease is the most commonest presentation of the cytomegalovirus. Here we are going to study specifically with the salivary gland related disease, that is the salivary gland inclusion disease. So cytomegalovirus, it's also a type of herpes virus actually. It has to be differentiated, cytomegalovirus has to be differentiated from cytomegalic inclusion disease, has to be differentiated from other forms like the toxoplasmosis also. So cytomegalic inclusion disease is actually an inapparent infection, that is subclinical infection. So there are no specific signs and symptoms for this cytomegalic inclusion disease. And in the salivary gland inclusion disease, you can see the parotid gland is affected and swelling of the affected glands is seen. And since the cytomegalovirus is transmitted through transplacental route or during breastfeeding, so mostly you can see few specific symptoms in cases of infants like hepatosplenomegaly, hemolytic anemia. This cytomegalic inclusion disease is such a infection that it is subclinical, but it has damaging effects that it may even cause the death of infants because of encephalitis. It affects the brain. And if the individuals survive also, there will be retardation of motor development, that is the developmental delay in walking, running, speaking may be seen. So salivary gland inclusion disease, it affects the parotid gland specifically, and there is enlargement of the parotid gland, swelling of the parotid gland along with pain in swallowing, mastication may be seen. So microscopically, this salivary gland inclusion disease, it shows that the cells are infected and they show presentation of both intracytoplasmic and intranuclear inclusion with prominent nucleoli. That is nothing but the owl-eye appearance of the cells. So this is with the cytomegalovirus. So now we will do with the other viruses, that is the enteroviruses. Enteroviruses are viruses which include the polioviruses, Coxsackie viruses, or the majorly known to us, that is the human immunodeficiency virus. So actually these are RNA viruses. So we have seen the DNA viruses previously. Now we'll go with the RNA viruses. So the most commonly affected oral disease by the RNA virus, Coxsackie virus, is the Herpangina. So Herpangina, it's also known as aphthous pharyngitis. It's not caused by herpes virus, so the name is little bit confusing. The Herpangina, it's caused by the Coxsackie virus. So clinical disease incubation period is about 2 to 10 days, and infection occurs through droplet spread, salivary contamination, or direct contact with the saliva, or direct contact with the persons affected. So this is a primary infection. It's most commonly seen in cases of children with no predilection. It affects both males and females equally. Here it is seen in the children and young adults. So it has been called as a summer disease. Though the infection, that is the attack, occurs during the summer, the virus enters the body. The body harbors the virus at the time of summer, but the clinical presentation are seen only months later, because once the virus harbors the body, it like remains latent in the body, it remains dormant in the body. So the chief presenting symptoms of Herpangina include the occurrence of vesicles on the tongue, pharynx, palate, buccal mucosa, gingiva. So the appearance of vesicles are characteristic as seen in other infectious diseases like the herpes simplex virus infections. So these small vesicles are maybe just about 1 mm in diameter, like that. They rupture to form ulcers which eventually heal. So other systemic presentations include the occurrence of headache, cough, vomiting, fever and sore throat. Majorly the vesicles, there are numerous vesicles which are scattered on the pharyngeal wall. So these vesicles are they are very painful in nature, so the patient will have difficulty in swallowing and speaking also. So here in the clinical picture you can see that there are numerous small vesicles which are seen on the pharyngeal wall. So they are exudative in nature. These vesicles rupture and they form ulcers which eventually heal. So this is extremely painful condition. Herpangina is extremely painful because of the erythematous nature of the lesion. A lot of inflammation and exudative reaction is seen. So microscopically, these vesicles are nothing but the intraepithelial vesicles seen previously, and they contain lot of eosinophilic exudate here. So and the epithelial cells, they show nuclear vacuolation, that is the nuclei is just pushed to one side with cytoplasmic vacuolation. That is nothing but the ballooning degeneration of nuclei, characteristically seen in the herpes simplex infections also. But this Herpangina is an extremely painful condition, so symptomatic treatment has to be given along with antiviral drugs to treat the virus infection. Other is the hand, foot and mouth disease. Hand, foot and mouth disease is also caused by Coxsackie virus, or it is also an RNA virus, right? So the hand, foot and mouth disease, as the name suggests, the infectious disease, the vesicles, whatever are seen, they are seen characteristically on the feet, the hand and the oral cavity. The clinical presentation is the one of vesicular appearance, that is exanthematous, maculopapular and vesicular eruptions may be seen. Before the development of eruptions, prodromal symptoms may be seen. There is the anorexia and the low-grade fever, malaise, lymphadenopathy and pharyngitis is also seen associated sometimes. Hand, foot and mouth disease typically occurs in children and young adults. So these vesicles are seen on the regions of hand, foot and mouth. In the oral cavity, whenever the vesicular or ulcerative lesions are seen, they are just very small in nature, isolated, or they may form group of clusters on the oral mucosa or buccal mucosa. Tongue and buccal mucosa and hard palate are the commonest sites affected by this disease. Again, the vesicle appears same as that of the other lesions seen. So microscopic diagnosis is essential. These microscopic diagnosis, it shows the presence of intracytoplasmic eosinophilic inclusion bodies. Cytoplasmic inclusion bodies are seen along with dense inflammatory cell infiltration. The characteristic appearance of vesicles on hand, feet and mouth 3 at a time gives the diagnosis of this disease, hand, foot and mouth disease. So and then the other commonest infectious viral disease which we see is nothing but the measles, also known as rubeola. This measles, it's acute infectious disease. It is highly contagious disease. It's caused by a paramyxovirus. It is primarily a respiratory infection, that is transmission from one person to occur through droplet spread or airborne infection. The upper respiratory tract is infected basically in this disease. The virus, it enters the upper respiratory tract, it just multiplies. Incubation period for measles is approximately 8 to about 13 days. That is, once the virus enters into the body, it may take about 8 to 13 days for symptoms to develop. And before even the rash develops or the cutaneous lesions develop, you can see a lot of prodromal symptoms affecting the individual. This disease, rubeola or measles, it is seen in children and younger adults most commonly. So the prodromal symptoms of measles include the appearance of fever, malaise, respiratory tract infection, cough. So the cough and all denote that the upper respiratory tract infection occurs. So it may be due to transmission or airborne spread of the virus. So once the symptoms begin, the prodromal symptoms begin, the rash begins after about 3 to 4 days of the beginning of prodromal symptoms. This rash characteristically it appears or starts on the face region, and then it spreads in the region of hairline and the region of neck and the region of face. The rashes begin to appear initially, then they spread to other body parts, the trunk and the limbs, etc. So oral cavity, when you see the oral cavity, the characteristic appearance of measles, they show the presence of Koplik spots. These Koplik spots are nothing but areas of erythema seen on the buccal mucosa. The Koplik spots are seen even before the development of cutaneous or vesicular eruptions on the body. That is, Koplik spots are like prodromal symptoms. They occur along with the prodromal symptoms. Most of the times these Koplik spots are not noticed by the patient. It's only the dentist or the medical personnel when they see a case and when they examine the oral cavity, when prodromal symptoms like fever and all are present, when they examine the oral cavity, these characteristic irregular bluish white macules which are surrounded by a red border, if they are present, they give a diagnosis of Koplik spots. The appearance of Koplik spots is characteristic only of measles. So once the prodromal symptoms develop and you see the Koplik spot and buccal mucosa, after a few days the rashes begin to develop. Once the rashes develop, the Koplik spots automatically they disappear. So Koplik spot is diagnostic of measles. And microscopic picture shows presence of multinucleated gain cells along with inflammation. These multinucleated gain cells are given a specific name called Warthin-Finkelney gain cells. That is nothing but the small, similar size multinucleated gain cells seen, but inflammation will be present here. So the measles also has the feature that it is highly contagious. Initially it is inoculated in the respiratory epithelium, and then it spreads through the reticuloendothelium cell or through the blood cells to variety of other body parts. So it has effects on other systems also, like it's causing a lot of complications like bronchitis, pneumonia, conjunctivitis, hepatitis. So all the systems are affected, like reticuloendothelial cells. So all the systems of wherever the virus gains entry are affected. So that's with the measles infection. So there is other common infectious disease called the rubella. Rubella is nothing but the German measles, also known as the German measles. It is different from the regular measles infection in that here the Koplik spots do not occur. That is the only differentiating feature between the two. And rubella, it's specifically the virus is transmitted from the mother to the child through the transplacental route. So during the first trimester of pregnancy, if the mother contracts the viral infection or the measles infection, then that remains transmitted to the fetus, developing fetus, and the individuals or the children affected show characteristic abnormalities of the heart, the respiratory system, or the central nervous system. So congenital heart defects are more common in children who are born to mothers who are affected with the measles virus. So this is highly contagious, and the only characteristic difference is, as I told you, complex spots do not occur. Similar shaped vesicles may be seen on the body and the oral mucosa. Everything, all the cutaneous eruptions and the prodromal symptoms all may be severe. But rubella is a more severe form of the measles infection. Mumps, it's also known as epidemic parotitis, right? So there is characteristic enlargement or bilateral swelling of the involved salivary glands, chiefly the parotid gland. The submaxillary or submandibular may also be involved few of the times, but characteristic is the parotid gland involvement. The incubation period is about 2 to 3 weeks. It takes 2 to 3 weeks for the symptoms to develop, and during the time, even before the symptoms, even before the development of symptoms, the disease is contagious. It's highly contagious. So once the virus enters the body, automatically the individual is ready to transmit the infection to other unaffected individuals. Transmission is by direct contact with saliva, that is through droplet spread. So this virus actually gains entry into the upper respiratory tract infection, upper respiratory epithelium. So once it's inoculated in the respiratory tract epithelium, it replicates, then viremia develops. That is, through bloodstream, this virus is just transported to other body parts, leading to systemic infection. This systemic infection, it shows effects on all body parts, like is the pancreas is affected. It shows that it has been associated with the development of juvenile diabetes if pancreas is affected by the virus. It affects the eyes, ears, testes, ovaries, and when specifically when it involves the parotid gland, it just keeps multiplying in the ductal epithelial cell, leading to damage of the acinar and the ductal cells of the parotid gland. So clinical features are nothing but swelling of the involved area, pain in the ear, pain in swallowing, and because of the involvement of parotid gland, you can see that the ear is just lifted above the surface because of the swelling, and systemic symptoms like headache, chills, fever, pain in ear may be seen. Along with that, the characteristic swelling swelling may be involvement of the lymph nodes present in the neck also. So bilateral involvement is more common, that we have to remember. Mumps involves bilateral involvement. Mumps virus has been shown to be a very contagious one, and because of the reticuloendothelial spread, or because the virus cells spread to a lot of other systems, so the complications of mumps infections are more common, like meningoencephalitis, deafness, mastitis, orchitis or ophoritis. All these systems are affected because of the mumps infection. Treatment is just the conservative treatment. So the pain in swallowing or pain in ear, they have to be relieved conservatively, and the swelling, it has to be treated conservatively. So mumps infection, you have to differentiate mumps infection from a lot of other infections, or a lot of clinical presentation of this mumps is similar to other diseases like the chronic non-specific silodinitis. So you have to correlate the clinical symptoms along with the isolation of virus, that is the paramyxovirus from here. So human immunodeficiency virus. It is a RNA virus, and we as all know that HIV virus is responsible for causing acquired immunodeficiency syndrome. A lot of debate and research is being going on presently in this viral infection, that is the HIV viral infection. So HIV virus, actually it's a RNA virus. It belongs to lentivirus group of family. Basically the HIV virus, it has two envelope proteins, namely the GP120 and the GP41. These two helps the HIV virus in holding on to the human cell surface receptors. So HIV virus, basically it multiplies in the macrophages of the human body. Once it enters the body, once it gains entry into the body, it basically multiplies in the macrophages, and it has varying effects or destructive effects on the immune system and the central nervous system of the body. There are two genetically distinct type of HIV viruses, that is the HIV type 1 and the HIV type 2, causing the AIDS disease in varied populations. Like the HIV type 1, it is mostly seen in cases of Western countries, whereas the HIV type 2 virus is most significantly seen in the Indian population. So how the transmission of HIV virus occurs? Basically the main routes of transmission are through exposure to body fluids or the blood products already containing the virus. So the sexual contact or the intravenous drug abuse was the major cause previously. Now it has the transfusions of blood or blood products or the intravenous drug abuse or vertical transmission from mother to child is also the route of transmission for HIV virus. 75% of transmission is occurring through sexual contact now. So what is the pathogenesis of the HIV virus? HIV virus basically, whenever it enters into the body, it gains access to the cell surface receptors of the human cell membrane. Because of the presence of the GP120 and the GP41 envelope protein, this helps the virion to bind to the cell surface. Mostly the T lymphocytes are the first to be affected in the humans. So once the binding of RNA virion to the cell surface occurs, then as we know that HIV is a RNA virus, right? Then reverse transcription occurs and the viral RNA, it is just reverse transcribed to viral DNA form. This occurs because of the presence of reverse transcriptase enzyme. So now the viral RNA is converted into the viral DNA. So this viral DNA is then transported to the host nucleus. It gets integrated into the nucleus. So then further transcription occurs, and at a later stage the viral DNA again is converted into the RNA factor, RNA genome, viral RNA, and thus in this way it goes on spreading to the whole of the body. And HIV virus, as we know, whenever it infects, first it infects the macrophages, multiplication occurs in the macrophages, and from there on it spreads to the lymphocytes or the lymph tissues, and then the lymphatic spread helps in widespread dissemination of the virus. So the clinical manifestations depend on the stage of virus inoculation or the stage of virus in the body. So there are wide manifestations like the acute infection, the initial symptoms which develop when the virus affects the body. Then there is chronic asymptomatic infection, then persistent generalized lymphadenopathy and AIDS-related complex. So acute illness, as soon as the person is affected with the disease, he shows the presence of illness, severe systemic illness like fever, arthralgia, myalgia, encephalitis, lymphadenopathy. All these are the acute illnesses. So once the acute illness starts from about few days after the infection to it lasts to about 10 weeks. So acute infections remain usually symptomatic, but not severe systemic illnesses are seen. And after the acute infection, the plasma viremia levels, whatever the virus levels are present in the blood, they reach to a very, very peak level. That is, you can find about 1 million molecules per millimeter of blood in cases of acute infections. So once the virus level reach peak into the blood, after that there is a steady state for the viral infection. During this period, there is no replication of the virus. So initially the viral level reaches the peak, then it just progresses at a steady state level. It remains constant like that. So that the disease is become dormant or it becomes masked. So initially you have acute infection, then the disease becomes the HIV infection. It remains dormant for period of many years. So as the disease progresses, then you see the chronic systemic infection or the chronic infection. That is nothing but the persistent generalized lymphadenopathy. So in the chronic disease process, you get to see that there will be lymphadenopathy of at least 2 or 3 sites which last for 3 months. The lymphadenopathy will be persistent for 3 months, and 2 extra inguinal sites will be involved which show lymphadenopathy. So during this process, the patient he remains asymptomatic. This lymphadenopathy is asymptomatic. Then there appears to be a period where the antibodies will not be detected in the peripheral blood, and that is nothing but the window period. So even though the patient has infection, you will not be able to detect it in the blood because of the reduction of viral load, as we have already seen. So the CD4 count is also affected. The CD4 count, according to the Center for Disease Classification, the AIDS or the acquired immunodeficiency syndrome, it occurs only when the CD4 counts have fallen below 200 cells per mmQ. And the acute infection, the acute manifestation of HIV infection starts when the CD4 counts fall below 500 cells per mmQ. Once it reaches below 200 cells per mmQ, it's an advanced stage of AIDS. Nothing but the AIDS related complex, also known as the AIDS related complex. So these are the clinical manifestations of the HIV virus infections. So these are the general systemic manifestations. Apart from these, there are a lot of oral lesions occurring, oral manifestations of the HIV lesion occurring. So as a dentist, whenever you see a patient and you see the following oral lesions, these oral lesions are giving a stronger indication that HIV infection is present. It may not be detected, it may not be known to the patient, but when you see such characteristic lesions of oral cavity, you can make a presumptive diagnosis of HIV infection. So as we have already seen, the systemic manifestations are nothing but the acute response and the window period during which the virus will be present and it will not be detected in the blood. Then asymptomatic phase, which shows the progressive generalized lymphadenopathy, and then comes the symptomatic phase, which is like with severe opportunistic infections of body, like the non-Hodgkin's lymphoma and neoplastic diseases. All forms of cancer will be developing. So here you can see the picture showing the acute symptoms of HIV infection. Almost all body is affected by HIV virus, because this virus affects the immune system and the central nervous system. Like whenever the immune system is affected, almost all whole of the body reacts to this process, and you can see clinical features like depression, weight loss, fever, oral cavity is affected showing pharyngitis, central nervous system is affected showing headache, or in cases of meningitis, encephalitis, or neuropathies. And characteristically the lymph nodes are affected, they show lymphadenopathy, and the appearance of maculopapular or vesicular lesions on the skin. And even the muscular system is affected, as the muscles show myalgia, and reticuloendothelial system, that is the liver and spleen, are also affected. So now we'll study the oral lesions of HIV virus. So there has been a classification proposed in 1993. It has divided the oral lesions into 3 groups, whether they are strongly associated, whether the possibility of occurring the lesions is there or not, and they are less likely associated with the HIV lesions. So group 1 include the lesions which are compulsorily or strongly they are associated with the presence of HIV infection. So when even the patient may not know that he is HIV positive, and when you see the association of this oral lesions, then you can suspect that the patient is an immunocompromised one, and maybe he may be suffering from some immunocompromised disease that you have to correlate clinically. So the oral candidal infections, they are more commonly associated with the HIV virus. Then the hairy leukoplakia, HIV associated periodontal lesions, Kaposi's sarcoma, and the non-Hodgkin's lymphoma. These 5 neoplasms or precancerous lesions or the oral conditions are more commonly seen associated with HIV. Then group 2 lesions are lesions which are less commonly associated. They may be present, may or may not be present association with HIV. These are nothing but the bacterial infections and melanotic hyperpigmentation and necrotizing ulcerative stomatitis. Group 3 lesions are lesions which are seen sometimes in HIV infection. These include the bacterial infection, the drug interactions like the epithelioid angiomatosis also, and the fungal infections other than the candidiasis, that is the histoplasmosis, blastomycosis, geotrichum, candidiasis, etc. And neurologic manifestations like facial palsy and trigeminal neuralgia and recurrent aphthous stomatitis. So recurrent aphthous stomatitis is like a commonly occurring oral disease. It may be associated with HIV infection like that. So we'll study the most opportunistic and the most strongly associated lesions with the HIV infection. First is nothing but the candidiasis. As we all know, candidiasis, it is a fungal infection. It is caused by the fungus Candida albicans, and it is the most opportunistic infection which is seen, because the Candida albicans, it is actually a normal inhabitant of the oral mucosa. In HIV affected individual, the patient is immunocompromised, the immune system is affected. So in such cases of immunocompromise and the usage of all the cytotoxic drugs, they lower the resistance of body. So, and the normal inhibitory flora are like reduced. So that predisposes to development of candidiasis in such individuals. And the lot of forms of candidiasis seen. Pseudomembranous candidiasis, also known as thrush, it is seen in debilitated individuals. It is seen in younger age individuals. The typical appearance of pseudomembranous candidiasis is whitish plaques on the surfaces, most commonly the tongue, the buccal mucosa or the gingiva. And these whitish plaques, they can be easily scraped off the oral mucosa, and actually these whitish plaques, they resemble milk curds like a thing. Mostly the pseudomembranous type is occurring in cases of infants like that. And the erythematous type of candidiasis, it is also known as antibiotic sore mouth. The erythematous type of candidiasis is actually occurs as a sequelae to usage of broad spectrum antibiotics for a longer period of time. Here the clinical appearance is of the plaques which are reddish in color, and they are very painful, extremely painful, and they cause a burning sensation of oral mucosa. They also may be seen on the tongue, buccal mucosa and posterior part of the hard palate. Then other form of candidal infection which is encountered mostly is the hyperplastic type of candidiasis. It's also known as candidal leukoplakia, because the white plaques which are present on the oral mucosa, they are not removable. Normally the candidal infection consists of whitish plaques which are removable, but this hyperplastic candidiasis is one where the plaques are not removable. So they give an indication that it may be a form of leukoplakia. So the name candidal leukoplakia. It is seen most commonly in the anterior buccal mucosa. And then next is the angular cheilitis. Angular cheilitis is nothing but the flaking or fissuring of the corners of the mouth. This is seen association with candidiasis also. So the flaking of angles of mouth, it is little bit painful and to speak or swallow. So here you can see the clinical pictures of candidiasis, oral pseudomembranous type of candidiasis in the first picture, and the second picture showing the infant. Whenever the candidal infection occurs in infants, it's known as thrush or moniliasis. So here it's a picture of candidal esophagitis, actually candidal pharyngitis. The posterior part of pharynx shows the candidal lesions. It's a severe form of pseudomembranous candidiasis. So the other most common lesion which is seen associated with HIV infection is the occurrence of oral hairy leukoplakia. The term oral hairy leukoplakia, it was given by Greenspan in 1984. There has been a strong association of oral hairy leukoplakia with the Epstein-Barr virus. According to a few authors, it has been proposed that Epstein-Barr virus, they normally inhabit in the lateral margins of the tongue. They are the normal inhabitants of lateral margins of tongue. So in cases of HIV infection, there is the diminution of all kind of cytotoxic cells. So even the Langerhans cells are diminuted, they are reduced in number. So that leads to reactivation of this Epstein-Barr virus along the lateral margins of tongue. So development of plaque-like lesions or vertical streaks, more commonly on the lateral border of tongue, that gives the appearance of this oral hairy leukoplakia. So whitish vertical streaks may be seen which are thickened or which show hyperplasia along the lateral borders of tongue. So the specific location gives an indication of this condition, oral hairy leukoplakia. Yeah, the lesions are asymptomatic and occasionally they may cause slight soreness or discomfort of the area. When you see a histologic picture of this oral hairy leukoplakia, you can see epithelial hyperplasia along with hyperkeratosis and acanthosis of that particular surface. So that it has a histologic picture of hyperplasia along with the leukoplakic condition. So, and the swollen balloon-shaped cells are seen in the precursor layer. This is nothing but the nucleus is just pushed to one side, giving the appearance of a balloon shape. And the superficial epithelial cells, they show condensation of the nuclear material. That is nothing but the nuclear beading or hyperchromatized nuclei are seen here. So, and along with this features of epithelial hyperplasia, you can demonstrate the presence of Candida albicans in the epithelial surface. That is, the demonstration of candidal hyphae is done by staining of the cytological smear. That is the PAS, periodic acid shift reagent, that gives the correct demonstration of this candidal organism. So the oral hairy leukoplakia is also it's a very characteristically seen in HIV affected individuals. Other is the Kaposis sarcoma. Kaposis sarcoma, it's actually a neoplasm. It's caused by human herpes virus type 8 virus. This neoplasm, it actually occurs in the buccal mucosa more commonly. This neoplasm is more commonly associated with HIV infection. Kaposis sarcoma is nothing but neoplasm of vascular endothelial origin. That is, it affects the blood vessels of that area. So the clinical appearance of the Kaposis sarcoma is the occurrence of nodular, ulcerated or macular. It may be a macule, it may be flat lesion like a thing. It may be ulcerated, it may show severe outgrowth or break of continuity of the epithelium, or it may be nodular in lesion. So, and they may show ulceration also, and the color of the lesion varies from red to purple. As the lesion, initially the lesion will be flat red macule, and as the disease progresses from red macule it becomes nodular, then ulcerated, and because of the involvement of the blood vessels it becomes darker with as the lesion ages. That is, it becomes purple in color, red to darker in color. So this Kaposis sarcoma, it's also strongly prevalent or strongly seen associated with HIV infection. Then the other periodontal lesions are the necrotizing ulcerative stomatitis, gingivitis, and the necrotizing ulcerative periodontitis. The periodontal lesions, they are most commonly seen in immunocompromised individuals. Normal periodontal lesions occur because of the presence of microorganisms like Fusobacterium, Prevotella intermedia, and Actinobacillus actinomycetum comitans. In HIV affected individuals also, the same organisms are responsible for causing the periodontal lesions, but because already the host is immunocompromised state, the host doesn't have any form of resistance, and it shows the aggressive nature of the lesion. The microorganisms, they are present in both the normal and the HIV affected individuals, but the manifestation of disease is more severe in the HIV affected individuals. So the linear gingival erythema, it's nothing but a very fine red band seen on the gingiva. It is a non-plaque induced one, so there is no association of plaque there. The linear band, it is just confined to the marginal gingiva. The marginal gingiva is erythematous in nature. And the necrotizing ulcerative stomatitis is nothing but the destruction, it involves the destruction of one or more of the interdental papilla. Necrotizing ulcerative periodontitis involves the destruction of alveolar marginal gingiva along with the alveolar mucosa. So there is severe bone loss in this periodontal lesion. And there are other forms of lesions which are associated with HIV infection, as we have already seen. That is the hairy leukoplakia and the non-Hodgkin's lymphoma. The non-Hodgkin's lymphoma is actually a B-cell lymphoma. It has the same presentation as seen in the normal individual, but the occurrence of such a debilitating disease, you have to just differentially diagnose that, rule out the occurrence of HIV in such individuals. And the presence of excessive hyperpigmentation either in the buccal mucosa or the gingiva, focal areas of hyperpigmentation should also be taken into account, the presumptive criteria for the diagnosis of HIV. And the recurrent aphthous ulcers, normally they are just the few millimeter in diameter, but when occurring in cases of HIV affected individuals or immunocompromised individuals, the normal ulcer, it will be about 2 centimeter in diameter. It will show extensive erythematous or inflammation with presence of fibrinous exudate. Treatment for HIV includes first the diagnosis. The diagnosis is done by oral lesions, which oral lesions give just the diagnosis of presumptive diagnosis of they may serve as entry points and exit points for the prophylaxis and the clinical therapy as such. But diagnosis is done by Western blot technique, Western blot test, and enzyme-linked immunosorbent assay test, polymerase chain reaction, P24 antigen detection, and the viral culture. The viral culture, it gives 100% correct diagnosis that the virus is the HIV virus. But viral culture takes many months to diagnose the HIV virus. So the more commonly the polymerase chain reaction test is used for diagnosing this HIV infection. The PCR, it's of 2 varieties. One diagnoses the DNA forms and the other diagnoses the RNA forms. As we have seen the pathogenesis of HIV infection, initially the virus had a component of RNA which was transcribed to DNA, and then when it was integrated into the host, it again became a viral RNA genome. So 2 types of PCR are present to detect that. It is relatively sensitive test. Only in window period, that is the asymptomatic period, you cannot detect the virus here. The PCR test results come off very fast, like in 24 to 48 hours you'll be able to diagnose it. And the other is the enzyme linked immunosorbent assay. For the Indian population, if the presence of a virus has been demonstrated by enzyme linked immunosorbent assay test, you have to repeat the test with the same different samples with 2 different kits. So when 3 kits show that the lesion or that the HIV virus is positive, the individual is given the diagnosis of HIV positive. Whereas the Western blot analysis test, it's not heavily recommended once the ELISA test is performed, but Western blot analysis test is more specific as it gives the diagnosis in the form of bands of proteins. The envelope proteins are present. There is the GP120 or the GP41 proteins. These appear as bands on the test. So these bands, the presence of these bands, appearance of 2 or more 3 bands gives the diagnosis of HIV positive infection. So after diagnosing a lesion, so you have to take proper care, because the transmission from one individual to individual, there are high chances. So you have to take care that the individual is, as we know that HIV is transmitted by blood or body fluids, right? So care has to be taken that you do not come into contact with the infected person's blood or body fluids. Saliva also has a few of the HIV virus, but there are a lot of debate, and it has not been proved that salivary transmission occurs. So there is no harm in sharing of food with the affected person. Only cautious nature should be the contact with the blood. And treatment includes the antiretroviral drugs, the zidovudine, stavudine, lamivudine, didenosine. They have to be given at regular intervals and as and when the symptoms arise. And we all know HIV, acquired immunodeficiency syndrome, it is a debilitating disease, and once the HIV infection occurs, after about the lifespan of the individual is reduced because the immune system is affected, and the 10 to 12 years after HIV infection, the patient develops severe immunocompromise, and severe AIDS, opportunistic infections are seen, and usually death occurs. So that's with all the viral infections of oral cavity, major viral infections of oral cavity.